So anyways, welcome to the Dr. Paul Show. I'm Dr. Paul. I have the honor of having a patient I've had for almost a couple of years, about a year and a half. He's with me, but I wanted to have him on because he has a really interesting story, and I'd love him to start to tell us about it. And so, and Joseph is a psychologist, PhD. And he's in New Mexico, and so welcome to the show, and tell us about everything.
Yeah, thank you. Thanks for having me. I really appreciate it. This is great. Well, let's see. I actually wrote out a whole timeline. I mean, go figure, me being organized and prepared. Um, so I actually grew up in Chicago to a primarily Italian family,
Mhm.
and you know how that goes. My family was very focused on, image, success, money, primarily my grandmother, and she really, instilled those qualities into me, not so much my brother. I don't know how he escaped it, but to me at least. And growing up, I was always first an anxious child with, these perfectionistic qualities. I didn't have that many friends as a child, and as a result of that, I threw myself into academics and spent most of my time studying. And I was probably always depressed, but it didn't really come to my attention, or I didn't really recognize what that was until high school. And
Even in like elementary school, looking back, even earlier in life.
Yeah, I might have been like sad a little bit when I was ostracized, or when kids, might have called me a name, like I was a little chunky, so they called me fat or something like that. But I don't think I really knew that I was consistently, depressed until high school. Yeah.
Mhm.
Um, so being the family that I have, my mom was concerned, and so she brought me to a psychiatrist. And my family believes in medication. We have pharmacists in the family, we have physicians in the family, so medicine is kind of in our roots. And they brought me to a psychiatrist, and for some reason, I don't know how he diagnosed me with OCD, but he did, and put me on Paxil, and it was brand name at the time. So I don't know if that gives away my age or what, but um,
A while ago.
yeah, thanks. So he put me on Paxil, and that was for a very short period of time because it was at the end of high school, and I was about to leave
Because
for,
yeah, so I would say you first saw a psychiatrist with like you're in like what later in high school then.
yeah, like my senior year.
Okay.
So then I moved to Phoenix for undergrad, and that was really when I had my first depressive episode, where I wasn't like completely in a vegetative state, but I definitely was very low, and it was a a dark time for a while. And so, seeing that I had just been with a psychiatrist, that actually was like months before at that time. I went back, and my grandmother was like, "That's it. We don't want anything to happen." She's like, "I'm paying for everything." So I went to the psychiatrist, and I saw him for about, what was it, 5 years or so. Yeah. And with him at that time, and I know, Dr. Corona, this is going to make you smile because this is your thing, but he put me on Effexor XR at that time, and Sonata to sleep. They were both brand name, I think, at the time too. So he had me on that, and I was on that, and I don't really remember feeling better or worse on it. That was such a long time ago. But all I know is he kept increasing the dose, and I was in like the 300s by the time by the time he retired, actually. So I remember having these persistent depressive symptoms, but then having these times of deeper depression. So it was like persistent depressive disorder, and then having these major depressive episodes then infused in
Did the effects
something.
make any difference at all, or not? Didn't it help or hurt or anything?
I really don't remember, to be honest. I don't. I mean, it must not have been working if he kept going up and up and up. So,
And the Paxil, how about that? Did that what happened with that one?
that was that was senior year, and it was so late before I was going to move that that physician at the time didn't want me to be on something and then not have a provider, set up. So he kind of tapered me off, which
Mhm.
makes sense.
Okay.
If you don't have a plan,
Right.
and
Good, right.
so that's what happened there. And some of these depressive episodes were seasonal, and it went on for years until recently. But I also remember being very irritable during those periods too, which I think is important.
Mhm.
Very short fuse, quick to being annoyed. Not, I wouldn't say angry, but there was an edge to me, I think.
Mhm.
And now that I look back too, like at how I was and how it was during the periods when I wasn't depressed, I think I had periods of hypomania even in college. I mean, I remember having high motivation, like I could study for hours and not even stop. I
Did you,
was, but I was also,
when you were doing
what's that?
that, were you, how was your sleep pattern? Were you sleeping a full night's sleep or no?
It's funny you say that because on Facebook you get these memory time warps or whatever that they give you these memories. I had posts way back in 2008. Can't sleep again. It's can't sleep again. I wonder if I'm going to sleep tonight. So I've always had sleep problems. But during all this time, I was still able to function without needing all that sleep. But at the same time, like when I was saying I was able to study this and that, I was still distracted by like extraneous sounds and my own internal thoughts and ideas too, were distracting. I could be happy and excited, but also irritable. I think I would make plans and start projects based on these ideas that I would have and get really involved in something and really invested and say I'm going to go 100% into doing something, and I'd buy all this stuff for it, and then it would fizzle out after a while, and that has persisted throughout life. What else would I do? I'd have these racing thoughts that the way that I describe it to people who haven't had this type of thinking is, imagine you have a thought and you have one Google tab go up, and then before you could even finish reading that page, another one pops up because you have another idea, and then you jump back to the one that was open already, but then a third one pops up, and your thoughts are happening faster than you can even act. And I remember that happening a lot. Um, I think sometimes it still happens, but that's one of those residual symptoms that I think it's because I get so excited too, about something. And anyway, so and I liked it. I liked the hypomania.
Hmm?
I think a lot of people do like hypomanic periods, which are different from manic, which we always have to tell people because those can be scary and really distressing for people.
Very
And,
distressing. And hypomania you can get by with for a while because you're high functioning, you get a lot done. Eventually, it doesn't last though, but people kind of like to ride that wave for a while as long as they can before things start to crash. Because you had told me that you were like seasonally, you would, feel different in the spring or the summer. Can you explain that? Or
yeah,
what pattern do you see during the year as far as seasonal?
yeah. I mean, I just did it just a couple of weeks ago. Like I dread all the time changes that we have to do. The one in the fall because of the darkness. That really gets to me. I think I start eating more carbs. I gain more weight. At that time, yeah, it's the darkness. And then in the spring, it takes me like a month to adjust because of the not the losing of the sleep, which I already have. My sleep is getting a lot better now, but having poor sleep, and then also the um, the light this time not being able to fall asleep. So I'm wearing, blue light blocker glasses and so forth, which really do work. Um, but I would get to answer the second part of your question. I think I'd have a little bit more hypomania in this spring because I'm looking back at patterns. I was like, wow, I took on a lot more projects in the spring than I
Right.
did in the fall. I took on an extra teaching assignment, or I would take an extra, whatever it was during that time and just be more excited. So the patterns were all there. I just didn't really know it at the time. Um,
Yeah, we
and
call it cyclical mood changes, which is very telling too,
yeah,
uh, of a underlying bipolar situation. Like I said, in the bipolar one, the mania, the irrationality, the paranoia, things like that, which is different than hypomania, where you don't get any of those characteristics. You're just super high functioning, but one characteristic is that you don't need as much sleep. So for example, I had like 3 or 4 hours last night, good to go, you know. So that's a very telling thing. If someone doesn't get that much sleep, but you can't get much sleep with hypomania because your mind is going, 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 going. So it's hard to settle the brain down. And uh,
yeah,
but yeah, like I said, it can last for a while because of the high functioning. And the other thing about bipolar is a lot of the subtleties are not recognized. The hypomania is often not recognized. The depression is often not recognized. It is different than maybe a unipolar depression. It's easier to treat. Um, and But the thing um, about bipolar disorder is that you know people who have it, like yourself, are typically more intelligent than other people who don't have it. I heard from a doctor. I went to a lecture and I really liked what he said. He said I tell my patients you have a gift,
mm,
and people might think it doesn't feel like a gift. Even he said, even people bipolar one with mania, that you have a gift. Your gift is the fact that you are smarter, you're more creative, and you're harder working than people who don't have it. And the good news is, it may not feel like a gift to someone who's suffering with it because it's the ups and downs, irritability, depression, but the good thing is it's treatable, and so if it's treatable, that, like in your condition, and we'll talk about more treatment in a little bit, but the fact that that's the case, that we recognize that the medical problem is treatable, that gives people with bipolar disorder a lot of hope.
you
And
know, you had said something on another episode about how it takes, I believe, 10 years before someone's diagnosed. I still think about one, how was I never given a questionnaire or ever asked about this? And two, when it would be asked, it was always about bipolar one. And so, of course, I'm going to say no to a lot of the things that they're asking me because it doesn't fit. And so it blows me away that all these people out there are not assessing and are not assessing correctly or more expansively.
we'll take it in your case, you were on Paxil and Effexor. So if I have someone on Paxil, well, I'm not a huge fan of Paxil, I don't prescribe it really, rarely. It's too sedating. It's too hard to get off of. Um, but the fact that you're even the highest dose of Effexor, and if you're not doing great, like amazingly well on the antidepressant, there's something else going on. And the fact that you were seeing a psychiatrist for years and that he didn't recognize that there was something else going on, that's very typical. it's not just primary care. Yeah, primary care struggles with diagnosis and treatment, but it's also psychiatry. So
Mhm.
yeah, the statistic that it takes 7 to 10 years and three to four doctors to diagnose it, not to just treat it, to diagnose it. So all that time and energy is spent treating the wrong thing, and doctors don't recognize it. And the thing about it is patients are going to lose hope. I mean, if you know how long you gonna a patient going to give a doctor to get the diagnosis and treatment right? You know, they're not going to wait 7 to 10 years. You know, they're going to drop out of treatment. They're going to say, I'm not going to go back into treatment again. It didn't work for me. Whatever the doctor gave me just didn't work, or it made me worse. And that's the current situation out there. So it's a really a dire situation, and that's what, it's upsetting to me, and that's what drives me to keep doing what I'm doing. Is I want to educate, like teach, like you teach. I want to teach also. But yeah, and yeah, I want to go into treatment more too. But with you also, go back to your childhood and your upbringing. How functional were your parents? And because it's also your upbringing is very telling as far as,
Yeah.
did your parents like have alcoholism, or what was going on with them?
No, as I look back now, I think both of them have some hypomanic qualities for sure. My mom has had depression and definitely anxious, GAD to the max,
Right.
or what we think is GAD, and that might just be again a bipolar spectrum.
And to the audience, by the way, GAD is generalized anxiety disorder. So it's the
Oh,
most,
sorry.
no, no, it's the most common anxiety disorder is GAD. Anyway, keep going.
And then my dad has had, now it's being treated, but it had untreated depression, I think, for a really long time, and anxiety. But I remember him always wanting to spend money, and my mom yelling at him about buying all kinds of things.
Hypomania.
So it's, there was definitely some hints of some of these things with them that I think about now, and I think about childhood as well. Same thing with my grandmother, and then my mom's um, oldest brother as well.
Yeah. Yeah,
You know,
because
it,
the family history is key, and that's what really drives this whole thing is genetics. That's the number one cause of, which is really means that whoever has these things like yourself, and you can't help it. You know, it's a genetic. It just, but like a lot of things are genetic, but people don't tend to judge people because of their, oh, you have diabetes, your family has it, or you have high cholesterol, or propensity to heart disease, or whatever. That seems like different to people because they say, well, that's different because that's a real medical problem. This other stuff is just some mental thing. So people write it off, as and don't take, a lot of people don't take this seriously, and they think, oh, everyone's got stress, everyone gets depressed, just get over it. Uh,
right.
and those are people who just really don't get it. They don't understand the subject at all, and they belittle people who have these things that, because they just don't acknowledge that these things are real.
Mhm. I think what would be important for everyone watching to know too, because you mentioned it. We're talking about starting in 2000 when I started with a provider and medication, and it took until almost 2 years ago, like when I was seeing you, um, to get it right. So that is an outstanding number of years, and we haven't even talked about all the meds that I've tried. But I just want people to know that there is hope for it and don't give up. I mean, I'm not saying be like me, but there is a way forward. There's always a way forward, even if it's not what you want. Um, there is a solution. I
And
think it's just
if the doctor's not giving them the results, you got to find someone else. You can't keep going to someone. It's people will switch if people don't get good service anywhere else, a grocery store, a hair salon, they'll go somewhere else. There's a lot.
right.
But when it comes to the doctors, for some reason, and even sometimes therapists too, they
Hmm.
stick with someone who they're not getting results with because they just feel this loyalty. Well, I have to keep going, seek out someone else, maybe has a different perspective. If anyone wants to see me, I'm available. I do phone, video, all around the country even, so you can always contact me if you want to get help or get another perspective. Because sometimes it just takes a perspective, an outside perspective to say like, something's not right here. And like in your case, it's, the doctor's got to take a really good history. And the fact that it started with you at a young age is extremely telling.
Mhm.
With unipolar disorder, purely like a easier to treat depression or anxiety, it doesn't usually start at a young age. It usually starts around puberty or after maybe middle school to high school. So the fact that it started so young with you is because your genetics is so strong. And and of course it can be unhealthy at childhood as far as parents and being raised, whatever. I mean, that can play a factor. But if someone has a pretty, not abused, not, has a pretty healthy childhood, but still feels depressed, and that's a signal that there's something more major going on than just a simple or unipolar issue.
Yeah, for sure.
Yeah. So, so with treatment with you, I know that when you saw me, you had tried the Effexor. We tried, I think, Prestige, and then you landed on Fetsema. Now, Fetsema is interesting. It's in the same family as Effexor and Prestige. It's a little bit different. It works more on norepinephrine, less on serotonin. And it seemed like with you, Fetsema seemed to be the best fit for you.
Yeah, I have a serotonin issue. Anytime I take a drug that's very serotonergic, it just doesn't uh, sit well with me. I'm tired all the time.
Right.
Just, yeah, it's now it works for a lot of people, but it just didn't for me.
Yeah. So, and again, something like Fatima or Prestige was right for someone that's kind of a good baseline medication to work off of. But it typically is going to take a combination. And also, we didn't talk about this too. You were diagnosed at a young age with ADD too. When was that diagnosis?
Actually, it wasn't super, super young. It was when I was living still in Arizona, but it was after college. Um, yeah, it was after college. I was seeing someone. That's when he put me on Cymbalta and Adderall XR um, as
Because the thing is with you, you're highly intelligent, and like I said, you studied a lot when you were younger. So a lot of people with ADD are extremely intelligent and can get by with work ethic and just trying harder, and you can get by for a lot of years sometimes until it kind of catches up, and it typically catches up college or grad school or when things start to get more difficult and strenuous. That's when the ADD can kind of come out more.
yeah, and your coping starts to break down at that time.
Exactly. So the Adderall, did you respond well to that?
I did, yeah, I did, and I think the only reason I didn't stay with it when I moved again after that was because that provider, I think, just said they believed in doing methylphenidates first. So that's when I went to Concerta, but I didn't feel like that was very helpful.
Okay. Yeah, Concerta is like very gentle, but it's often not quite as effective as the amphetamine class, like Adderall or Vyvanse, which I know you're currently on. Um, but uh, but yeah, I think after the Fetsema, what came next? I think I can't remember exactly, but
What we're doing now, you mean?
well, I know you had tried Caplyta. I think you tried Caplyta. I think before you first saw me, you were on a very low dose of Caplyta, which is a we call atypical antipsychotic. And again, when I say antipsychotic, it's not for often. Most of the time, it's not for psychosis. It's for bipolar. And you did okay with that. I think then we stopped it, because I think you got side effects or it was too sedating or
Yeah,
um,
too sedating with the combination that we had.
right. And then I switched to Vraylar. I think we got eventually to Vraylar, which is what you're on now,
Yeah.
which is a really good medication. And Vraylar is really, and people might see TV commercials about it because it's name brand. But yeah, Vraylar is a rock star. It's very subtle. It helps with the depression. It helps with the hypomania.
Mhm.
And so you're on that. I I think within a few months ago or so, I added Lamictal. Is that about right? How long you been on Lamictal now?
Yeah, a few months ago, we of course, did the titration that you have to do, and I'm up to 200. So
Right.
that's about the
That's made a
place.
big difference, you said.
Yeah, I think so. It
Yeah,
really.
lamotrigine is kind of a sleeper, and not a lot of doctors think about it. But I think about it because it really kind of helps with, taking the bottoms out. So sometimes because we see depression and we see hypomania, and then we kind of see this up and down. So basically the Abilify, I mean the Vraylar kind of evens out, and it kind of prevents the hypomania and some of the depression, and then the other is the antidepressant, Lamictal takes away the bottom, so Lamictal kind of prevents this dipping. So the whole point with this disorder is to kind of get more like this, like we know where you still have emotion, which sometimes SSRI, you get a lack of emotion, but you have emotion, but you're able to handle stress better, so it makes you more in control.
Right.
And
And
then I think, and then you are on Vyvanse now, which is a really excellent ADD medication, very popular. Um, so you're on a really good, right? Oh, and then the lithium. So tell us about. I know we put some lithium in, and tell us about that a little bit.
yeah, so we decided to do that, and I say we because Dr. Corona is very collaborative and believes in the collaborative process of medicine, which not everyone does. So I think even more importantly, I just have to say this as an aside. More importantly, sometimes than assessment is the listening aspect, and that's one thing that I think you do really well to really understand the patients is to listen to what's going on instead of just going down the road that you may want to go. So I really appreciate that. I'm sure other patients do too. So what we had decided was since there was some residual like irritability that you're like, well, why don't we bring lithium back in again and titrate it as you see fit or as it's working. So we started at the 300 milligrams, and I just went up to 600. So we'll see how that goes.
And that's pretty low dosing. And lithium, it has a lot of name recognition because most people have heard of it, but it's really, very old school. It's been around for a long time, and doctors don't think about it as much because with all the new fancier medications like Vraylar, like Caplyta, which get a lot of attention, and they're very effective. But really in this field of medicine, it's all about combining. Really, with what I do, it's combinations and getting the right combination together. And so with lithium, with you, I mean, normally the average range of dosing is about 900 to 1200 milligram a day on lithium, and now we're looking with you at like 300 versus 600, so just like a low dose. Because with what you're taking already with the Vraylar,
Yeah.
it's not gonna take a lot, but that little bit of lithium might just take away that edge, but we want it to take the edge away without making you sedated, and how is that feeling so far between 300 and 600?
I think it's going well. I'm paying attention very closely to see what I feel like during the day. And I'm basing it on if I have a night where it's not like horrible sleep, because then that's not really accurate to say that like, oh, it's too
Right.
sedating or something like
Right.
that. I think a lot of people just don't want to use it as well because they don't want to deal with labs. I hear that sometimes, you know,
Yeah,
but
it's such a low dose. We don't have to get labs too often because the labs are more often for looking for toxicity if we go too high. you're not going to be at too high, 300, 600 range. So, but we kind of keep an eye on kidney function and thyroid. There's things we'll keep track of with someone's on lithium, but normally I rarely see any issues with it. Uh,
Yeah.
and so yeah, you're on I think a really good mixture now, which is and yeah, like what you said before. I mean, doctors basically are really good at talking, but we're not really good at listening. Because like, well, we're so smart, so we're going to tell people how smart we are by talking so much. No, so it's a collaboration, but the key of communication is listening. And with what I do, it's all about history. I have to listen to people, but it's detailed history. And again, if your psychiatrist before would have done that, they might have picked out that, hey, there's something more going on here. There's something, but again, they didn't. And so, which is again why that statistic is there, why it takes so long, and so many doctors eventually figure it out. It's what drives me, and this is what's driven me. That I have the 4 books out, but I'm editing 2 books now. I told you about that are training manuals because I want to teach, and so I'm writing those books. I'm editing the books now that I wrote, and then the other thing exciting with you is that which is kind of unusual, that as a psychologist that you're actually being trained to be a prescriber, which is really exciting. I think that's fantastic. I think with you, with your experience and knowledge, you're going to be a great clinician too, as far as prescribing, because you get it.
Because I've been on all of them.
And you've read my books, and I'm actually gonna send you both of them when I'm done editing them. I'm gonna send them over to you too, so you can take a look at them and maybe see if there's anything there that you think could be changed. So yeah, I'm gonna wait. So once I'm done with my editing, I'm gonna send it to an editor, but when I get to that stage, I'll send it over to you too.
Yeah, that would be nice.
So yeah. So anyway, but yeah, and anything, but because I know you're pretty busy with practice, with teaching, right? So, but yeah, but I think you're gonna see when you prescribe, it's really fun. It's very fun to do what I do. It's fun to figure it out. It's like figuring out a puzzle, figuring out the person. I call it a living puzzle. One of the chapters in my book is called "The Human Being, the Ultimate Living Puzzle," because it's trying to figure out the puzzle pieces, and that's how I look at medication: puzzle pieces to try to complete the puzzle of the person. And so, yeah, I think you're gonna really enjoy it, and we can
I do too. Yeah.
collaborate in cases maybe at some point too. So, but yeah, so but it's been a pleasure. But anything else you'd like to add?
Um, for the audience or for the story or which one?
Either.
Oh,
Uh,
it doesn't matter. I think really hitting the point home that do not give up and don't get discouraged when 1, 2, 3 medications or a combination does not work, because there's at least half of an art in this as there is the science, and um, you will get there even if it takes 15 or so years. I don't even know how. I don't know what's inside of me that made me want to keep going without giving up, but there was something there. And you know you will get there, and there is a possibility to feel good and have a life that's worth living. So I guess I'll leave it there.
Yeah, and but I urge people to don't give it too long. In other words, yes, I mean what I do, like I said, I have to be wrong to be right. So I make the wrong decisions every day because with this field of medicine, we don't have the typical blood tests, and so it's trial and error. I call it rational trial and error, but science is trial and error. That's what makes science. And you have a hypothesis. You see, okay, let's see if this works. If it doesn't work, okay, well, you know what? that was wrong. Let me rethink this again. It must be this. So there's a lot of that happens with what I do. So I don't get every choice right, of course not. But I get it right once I figure out. I can figure out pretty quickly what's going on, and so yeah. But sticking with it, like you said, is very important. But also, like I said, if the doctor is trying combination even, and they're just not getting there, and they don't seem to have any new ideas, and a person starts to feel stuck and hopeless. Don't give up. Like I said, find another doctor who can help you. You know, not just in selling my books, but get my book or one of them or them and give them to your doctor as a present and say, can you read this and see if this gives you ideas, or like I said, see me. But yeah, but I think your message is great. I tell people this all the time, don't give up hope. And then when I see a patient, I said, let's do this, let's do that. I said, but don't worry, if it doesn't work out, I have an idea. What will I said, I have a backup plan, and I'm gonna put that in if this plan doesn't work. So, but that's a great message to close on, is to keep hope alive. So,
And thank you for everything and for being patient. And I know that my anxiety sometimes can be difficult to deal with too. So I appreciate all your support.
been a pleasure to work with. And
Yeah.
all right, doctor,
Okay.
take care. You take care of yourself.
Thank you. You too.
Bye.
Yeah, so in the case of Joseph, really, really interesting case, and he's been like a fun case because he's fun to work with. Like I said, he's a psychologist, he's a PhD, a super smart guy. And like I said, the interesting thing is he's in a program now where he's learning, and he's going to be qualified to prescribe medications. So which he's very excited about. And then the journey with me, he's really excited now because he's really understanding the issue now more. And he's read all 4 of my books that are out now. I have 2 more coming. And so he really gets it now. And so he's very, very into the details, which is fun with him because he's a fast learner. So he's tried different things. He was on Fexer at one point. I think he was on Cymbalta. He was on Prestige. And for him, actually, he was on Fetsima, which is an SNRI. It's the one I use the least, where it has a low serotonin, high norepinephrine. So the other ones are a little more even between them. But he's tried them, and Fetsima is the best for him. So he's happy with Fetsima. And that's working again, serotonin and norepinephrine. So now we got those 2 going that way, which is good. So, but again, he's a tougher case because he's a bipolar patient. He's bipolar 2 disorder. So, bipolar 1 is when you have mania, but with him it was hypomania. So high functioning, rapid thinking, super creative. You don't need much sleep. So the difference between a hypomania and depression or anxiety is if someone with depression and anxiety doesn't sleep well, they feel terrible the next day. You can tell the difference between that or bipolar disorder with hypomania when, again, they can sleep very little bit and they function just fine. It's almost like they don't really feel it or don't really care. So with him, we try different things, but he's on Vraylar for the bipolar, which is a great new medication. You might see commercials about it. But Vraylar is a dopamine antagonist. I think he tried Wellbutrin at one point and it didn't go well. So we know that dopamine was going the right way, but it's going too fast. So Vraylar basically slows it down. So it instead of going so fast, it just makes it go. Again, it doesn't stop it to the point where it's not going to go through. It's just, we want to try to get it through as a normal pace. When I'm mixing things together, I'm looking for normality, everything going the right way, not too fast, not too slow. I want perfection here. Perfection means everything is perfectly balanced. So he's doing very well with Vraylar. Seroquel, he still had problems sleep. He's on a low dose of Seroquel, which I use a lot for sleep. Again, dopamine antagonist, slowing down dopamine so that he stops his brain at night so he can actually sleep. And then also he was interested in trying lithium, which I don't prescribe a ton of it. I do have patients on lithium. It's really an old school medication, but it's a good one. It's still a good one. It's not really it's a more complex medication. Maybe I would think of it more along the GABA line, but it's basically a mood stabilizer that's very unique. And in his case, like I said, he tried it before. I think maybe he said he went a little bit too high, and so we're just trying on a very low dose of it. And he already thinks, at 300 versus 600, he's already seeing improvement, and that'll probably be the last piece with him. I think that probably is all we need to do with him, and he's going to be good to go. So, but yeah, he's also a really interesting case, a little bit more complex than the average case I see, but I love that. I love to be challenged. I like to try to figure this out, and challenging people to me are really fun because it's fun to see them get better, and it's very satisfying and rewarding when you see people who've been struggling for so long, and people who've seen other doctors who haven't been able to figure it out. I really love seeing those people because I like figuring out something, and that's why I do it. So, anyways, very good result with him.